to all who are in attendance on the phone, and we'll get started. So throughout the presentation, you'll find out about resources and tips about such issues as filing insurance appeals, coordinating benefits, and resolving debts resulting from healthcare costs. You'll learn about governmental programs and their criteria and provisions made available by the Affordable Care Act, or more generally known as healthcare reform. So, Elizabeth, I'm having trouble advancing the slides here. Are you able to do that? Elizabeth, can you hear me?
Yes, I can hear you. I won't be able to do that from my computer. Maybe try, oh, there you go.
Oh, there we go. There we
okay.
go. Issue resolved. Okay, so who is Patient Advocate Foundation? We're a national 501c3, and we've been around for 17 years now. We're headquartered in Hampton, Virginia, and we have offices in Virginia, Florida, Iowa, California, Georgia, and Texas. And we facilitate access to health care for Americans with chronic, debilitating, and life-threatening diseases. And our mission, we safeguard patients through effective mediation, assuring access to care, maintenance of employment, and preservation of financial stability relative to those conditions. We were founded in 1996, and since that time, we've provided direct sustained assistance to more than 780,000 patients. We've also, our case managers have also made over 1,400,000 contacts on behalf of patients to relevant stakeholders in order to resolve many different types of access issues. We've also saved over $26 million or obtained that kind of relief for PAF patients through the negotiation of write-offs, access to charity care, and resolving coding and billing issues or errors. And our case management department, again, I said we've been around for 17 years. We've provided that sustained case management service to patients with a variety of illnesses. About 80% of those are forms of cancer. And as you'll see, there are a number of services that we provide. Of those, we negotiate access to pharmaceutical agents, chemotherapy, medical devices. We negotiate pre-authorization approvals and resolutions to coding and billing errors. We provide assistance in expediting applications and approval for SSI, Supplemental Security Income, and Social Security Disability insurance. We resolve insurance enrollment issues in both the public and private sectors. We help to coordinate benefits. We provide appeals assistance for insured patients. We also try to negotiate insurance coverage for clinical trials and emerging therapies. We assist with applications to copay foundations and free drug programs, and resolve debt crisis issues. And the patient's journey now. Our patients really come to us with a multitude of issues once they're diagnosed, a number of challenges, and you'll see on the screen that they're kind of broken down into subject areas. Folks obviously have non-medical cost of living issues related to their illness, such as rent and mortgage assistance, eviction and foreclosure, now perhaps more than ever, basic needs such as food, transportation, lodging. They may also need to learn how to access state and federal programs, such as assistance with Medicaid and Medicare applications, and again, Social Security. And we'll go over some of those a little later in the presentation. Many patients will come to us with access to care issues. They may be uninsured. They may need to apply for hospital charity care. They may need guidance around clinical trials and also indigent care programs available in their county. They may be underinsured, and that's really the focus of our presentation. They may need appeals assistance, and Tanya will go into great depth about insurance appeals a bit later. They may need to or may benefit from risk pool insurance plans or a new provision within healthcare reform called the pre-existing condition insurance plan. They may also have employment issues. They may have experienced reduced pay or hours at their employer. They may be facing job discrimination, loss of salary or position due to their illness, and they may have question or need guidance around FMLA, which is the Family Medical Leave Act, COBRA, and then their short-term and long-term disability benefits. Many folks face out-of-pocket medical costs that are overwhelming and unmanageable. They may not be able to afford their insurance premiums, their deductibles, their out-of-network, additional costs, the costs of durable medical equipment and supplies, and then copay assistance we see quite often for medications, chemotherapy, their routine doctor visits, etc. And so we have a program within the foundation called Copay Relief. Some of you may or may not be familiar with it. We provide direct financial assistance to insured patients who cannot afford their co-payments and co-insurance amounts that their insurance doesn't cover. And that includes Medicare beneficiaries and those privately insured who medically and financially qualify. And going a little bit more into the approval process, eligibility is based on certain criteria. You have to have a qualifying diagnosis verified by a physician and be below a certain income threshold, which is 500% of the federal poverty level. And to put that into perspective, that's approximately $110,000 for a family of 4. And that criteria is adjusted for cost of living adjustment based on where you reside, where you live across the country. And then approval typically takes between 1 and 2 days once they receive all the required documents. And there are 4 entry points or ways to apply really for the Copay Relief Program. You can do it by phone, and you see the phone number there and the hours of operation on your screen. You can also access one of 3 portals. There's a portal for patients, one for your provider, and then one for the pharmacy. And then I'd like to go into disability programs. Now, Social Security as a federal benefit is often a gateway really to insurance benefits such as Medicare, Medicaid, or also for COBRA extensions. And both the disability benefit and SSI, or supplemental security, are really the largest of several federal programs that provide assistance to people with disabilities. For SSDI, you must be deemed disabled and have earned a sufficient number of work credits in a given period of time, and then the monthly payments are based on your earnings records. And SSI is really a need-based program. You must also be deemed disabled by the same criteria, and you don't have to have those work credits that you would have to have for SSDI. You have to meet certain income and asset guidelines, and as long as you can collect at least $1 in SSI, you're automatically eligible for Medicaid regardless of the state in which you reside. Now, Social Security also has an obligation. In the last few years, this is kind of a new change in the way they flag or prioritize cases. They're obliged to provide benefits quickly to certain applicants with certain conditions that are so serious that they obviously meet disability standards. And currently, there are 200 conditions that you can visit at the link below the slide that will automatically or expeditiously qualify you for Social Security disability. And at that link also, you can view for each disease or each condition, there'll be a pathology that's very understandable for the layperson or layman that will kind of explain the condition and give you more information. And so ways to obtain coverage. Of course, you can obtain coverage through an employer group, through your job. You can purchase an individual policy in the private sector. There are risk pools that we'll go over in more depth. I think Tanya will go into depth later on in the presentation. They're state issued and also federally issued, and they're available regardless of the state in which you reside. Also, the pre-existing condition insurance plan, which Tanya will go over a little bit later, is part of healthcare reform. It's a provision that's available to folks who have been uninsured for 6 months and have a pre-existing health history. And also governmental programs that we'll go over in some depth, namely Medicare and Medicaid. And now, if you have an insurance policy, we urge you as case managers at PAF to know your policy, and that simply means to read the insurance plan language or document, and not just the benefit summary or insert that they'll provide you. Understand the type of policy you're dealing with. Review covered benefits and also non-covered benefits and exclusions. And also, make sure you understand what the monetary limits of coverage are on your policy. Annual or lifetime maximums, and you'll see that asterisk there. As a result of the Patient Protection and Affordable Care Act, newly issued policies cannot impose a lifetime maximum. So, for example, if you have a form of cancer, for example, that's very high cost, you won't be excluded, or you won't reach a lifetime maximum benefit at any time for newly issued policies. You want to know about limits, or about your deductibles, of course, about your copays, coinsurance, and out-of-network costs related to your policy. And is there a limit on specific benefits such as home health, outpatient therapy, transplant coverage? We see that very often for folks in need of an organ transplant or a bone marrow transplant. And then, are there limits on the number of visits you have during a calendar year, or any sort of caps related to visits? And now we would go into a comparison of Medicare and Medicaid. Now, Medicare, we know, is federally funded. It's for individuals that are 65 or older, and then people with disabilities who have been on Social Security disability for a period of 29 months from the onset of their disability, and then those folks who are suffering from end-stage renal disease, and also ALS, or amyotrophic lateral sclerosis. And it covers limited services. As opposed to Medicare, Medicaid is federally funded, and also state funded, and in some cases counties can contribute to the program. Eligibility is determined by income, resources, and many times other eligibility factors. Now, for enrollment into Medicare, you have an initial original enrollment, and that can be due to your age or your disability status. You have 3 months prior to your effective date, the month of your effective date, and then 3 months after. So it's quite a healthy window of time during which you have to enroll in original Medicare. And this is also the same time period that's guaranteed for enrollment into a Medigap supplemental plan. There's also special enrollment that's quite important to take note. If you happen to not take Medicare Part B for your outpatient care when you were first eligible, you can sign up anytime you're still covered by the employer or union group health plan, or through your spouse's current or active employer. You can do this during the 8 months following the month the employer or union plan coverage ends, or when the employment ends, whichever is first. And now when coverage starts, that's usually the first day of the month in which you turn 65 and have those 40 working credits or quarters based on your Social Security earnings. And again, like I said, you would qualify also as a disabled individual under the age of 65 in the first day of the month following that 29-month waiting period. You're also eligible if you're suffering from end-stage renal disease on the first day of the 4th month of dialysis treatment, or in the first month when you receive a kidney transplant. And also there are rules around coverage if you suffer from ALS. And so if we go over the different parts of Medicare, Part A covers all services received during a hospitalization or inpatient admission, and also for home health services. Part B covers services received on an outpatient basis, and that's your routine doctor visits, your diagnostic testing, lab work, anything that can happen on the day of and day out of a doctor's office. And then Part C is coverage that you contract out to a private company, and it's usually associated with a term called an Advantage plan. You can also choose to take Part D coverage at the same time, and Part D is coverage for self-administered drugs. And so during an annual open enrollment period that has passed, you can change your Medicare plan, drop or join into Medicare, and that's during October 15th to December 7th of every year. And you can make elections or join or changes into Parts A, B, C, and D during the same period, and then those changes are effective on January 1st of the new year. And the open enrollment for Part B, or I should say late enrollment, is January through March with an effective date of July 1st of that year. And of course, if you qualify for extra help, which is a special Medicare subsidy for those individuals or married couples with incomes at a certain level, you're eligible to enroll or disenroll from your Medicare Part D plan every month. And if we talk about coordination of benefits, now this is for individuals who have a secondary insurance. In the case of the person who's 65 or older and covered by their group health plan because you're still working, or if you're covered by your spouse, then Medicare would be the primary payer. They would cover primarily, and your spousal plan or other secondary coverage would be secondary. And then there are rules around the number of employees. You can see that clearly on the slide. In the case where you're 65 or older and have an employer group health plan, then Medicare is always primary to the retiree coverage. And if you're disabled and covered by a large group plan, then Medicare is primary when the employer has less than 100 employees. Now, for seniors who reach the coverage gap, or you may have heard it termed the donut hole, and this is a phase in your drug coverage when seniors or other Medicare beneficiaries really experience the greatest hardship around the cost of their drugs. Now in 2013, fortunately, folks will receive a 52.5% discount with their brand name drugs and 20% off of their generics. And over the next 7 years, leading up to 2020, that we expect that donut hole or coverage gap will close entirely. Also, seniors and other Medicare beneficiaries are eligible for free preventative services, and those can include, your standard annual wellness visit. Those can include cardiovascular screening, mammograms, gynecological cancer screening, colorectal and prostate screening, bone density tests, and a diabetes screening and supplies. And those are free of cost. Now going into Medicaid, how that differs, it's federally funded, as we mentioned, and state run, and it's determined by income and resources. And there are categories that we'll go into in greater detail, including age, blind, and disabled, and families with children. And as a result of the Patient Protection and Affordable Care Act signed into law, there'll be an expansion of Medicaid eligibility effective January 1st of 2014 for individuals with income up to 133% of federal poverty level. And then states also will have the option to increase this income threshold. But of course the details are yet to be determined, and we're not sure which states will opt to do that. And here are the Medicaid covered groups. So those folks who meet income and asset criteria, who are pregnant women, of course children and teenagers, aged, blind, and disabled. Then the next three on the list are really Medicare savings programs. So the qualified Medicare beneficiary is someone who is Medicare eligible and of a certain income, and that benefit would cover out-of-pocket costs that Medicare does not cover, premiums, co-insurance amounts, and the like. And the next two, SLMB and QI1, strictly cover that Medicare Part B premium, which is, I believe, $106 or so. So that wouldn't, for someone who's eligible for those benefits, they wouldn't have to pay that additional premium. And then folks with SSI are automatically eligible for Medicaid. Folks who are diagnosed with breast and cervical cancer and below a certain income level are eligible for Medicaid. There are also emergency services that are available to immigrants regardless of residency status here in the U.S. We'll also talk a bit more about medically needy and spend down options, and then a little bit more about the health insurance premium payment program. And so medically needy, you might see it termed as a Medicaid buy-in or a spend down option. Those are different terms for it. And these are for folks whose income or assets exceed traditional Medicaid limits. Usually you have to incur medical bills that exceed the spend down or share of cost amount, and it works like a deductible. And some states require individuals to pay their share of cost first, but usually it's based on incurred medical expenses. And you'll see here the states that offer spend downs and the ones that don't. I won't go through each one of them. I'm sure you'll all be made available the slide deck, and you can, depending on where you reside, you can have a look at what your state offers.
Yeah, I'm just going to interrupt you, Brendan. We have gotten a lot of questions about getting a copy of the slides, so I think you can either email me or you'll be able to email Brendan directly probably for a copy of the slides. Is that right?
Absolutely. In any event, we'll make it available to all of you.
Okay, great. And we'll also have the video of this presentation up on our NeedyMeds YouTube page as well.
Great.
Okay.
Thanks, Elizabeth.
Yep, no problem.
Okay. So we are moving forward to the HIP program. Now this is the Health Insurance Premium Payment Program, and it's available for those who are Medicaid eligible and have some form of private health coverage through an employer group or an individual policy. So what it does, it's a cost-effective measure that the state affords the patient, and it would cover your premium and usually co-insurance amounts and deductibles. And you'll see the number of states there at the bottom of the slide where this program is available. And then that link at the bottom, it's a PDF file. Of course, this will be made available to you, but you can have a look at that, and it'll go through kind of the states that offer it and the details around each program. And now about Medicaid expansion. We kind of touched on this briefly before. Beginning in 2010, the Affordable Care Act required states to begin covering all adults and parents and those with dependent children. In 2014, that income guideline or threshold will go up to 133%. And like I mentioned, there are certain states that will be a bit more flexible and accommodate more and more people with higher income. And as a result of the recent Supreme Court decision that you can follow at www.coverage-counts.org, you can kind of have a look at which states are electing to expand coverage, even though the details really haven't been determined quite yet. The dust quite hasn't settled on that. But you can have a look at that site, and it will allow you to periodically check how your state is deciding on it or making determinations. And at this point, I will pass it along to Tanya to talk about appeals and the rest of the presentation. Tanya?
Good afternoon. Thank you, Brendan. I'm going to get right into types of appeals. This is something and a subject that is near and dear to me. I would absolutely work an awful lot of insurance appeals here at the foundation. And there are three types of actual appeals that we can start with. If there has been a pre-authorization, which is services that are requested prior to being rendered to make sure that it's good with the carrier, there are certain rules and regs that have been set up for the appeals process for these types of appeals. Under ERISA, the insured has about 180 days from the date the EOB to appeal. Again, some plans extend this to about a year. The insurance company at that point, once you submit an appeal, has 30 days to respond. If the denial is upheld, the insured has another 30 days to request the next level appeal. And again, the carrier has 30 days to respond. A post-service claim would be one that has happened after the fact. In other words, you've gone into the hospital and you've had some surgery done, or you need to go to the oncologist and you've already started some chemotherapy. Under ERISA, the insured has 180 days from the date of the EOB, which is the explanation of benefits, to appeal the denial. Some plans will extend this again to a year. Insurance company at this point has 60 days to respond. And then, of course, we go back and forth. If the denial is upheld, the insured has 60 days to request the next level, and then it volleys back to the carrier, and they have 60 days to respond. An expedited appeal is a little bit different in that would be an appeal that is based on an urgent matter. The patient's life is at risk, and a decision has to be rendered within 24 to 48 hours. We usually refer to this as something that is life-threatening, that a patient has to have in order to sustain life. And under ERISA, the insured can request telephonically an expedited appeal upon receipt of the denial. The insurance company has 24 to 72 hours to respond, and if the denial is upheld, the insured again can request the appeal upon receipt of the denial. The insurance company has 24 to 48 hours to respond. And for those of you that are not familiar with the acronym ERISA, the Employment Retirement Income Security Act of 1974 is a federal law that sets just the minimum standards for pension plans in the private industry. And it basically is a federal guideline that assists the employers and the employee in when they tailor and put their benefit plans together, their pension and their welfare benefit plans, which is your medical. So you're looking at pension, which would provide a dollar amount, and welfare benefit plans, which provide the insurance. Next. An external review of plan decisions to deny coverage for care based on medical necessity, appropriateness, healthcare setting, level of care, or effectiveness of a covered benefit. Clear information for consumers about the right to both internal and external appeals, both in the standard plan materials and at the time the company denies a claim. Expedited access to external review is another guideline that in some cases, including emergency situations or cases where their health plan did not follow the rules in the internal appeal. And then another route would be health plans must pay the cost of the external appeal under state law. States may not require consumers to pay more than a nominal fee. Another kind of layer, if you will, is a review by an independent body assigned by the state. The state must also ensure that the reviewers meet certain standards, keep good records, and are not affected by conflicts of interest. Emergency processes for urgent claims and a process for experimental or investigational treatment. And final decisions must be binding. So if the consumer wins, the health plan is expected to pay for the benefit that was previously denied. And while I understand that this slide all by itself is a wealth of information, I think it's important to understand where your plan originates, since many of us on the call are in different states. You would have varying state laws. So in other words, if you lived in Massachusetts, then you're going to absolutely make sure that you go about according to the laws in that state. Next slide, please. Internal appeals must have an appeals process that, one, allows the consumer to appeal when denied a claim for covered service or rescinds coverage. Two, gives consumers detailed information about the grounds for the denial of the coverage. Three, requires plans to notify consumers about their right to appeal and give instructions on how to begin the appeals process. Also have to ensure a full and fair review of the denial, and they also have to provide consumers with an expedited appeals process in urgent cases. We will be discussing the appeal guidelines for Medicare a little bit farther down in the presentation. These actual guidelines are for non-Medicare plans. The right to appeal decisions made by their health plans through the internal process, the right to appeal decisions made by a plan to an outside independent decision maker, no matter what state they reside or what type of coverage they have. And states will also work to ensure or update their external appeals process to meet new standards, and consumers who are not protected by state law will have access to a federal external review program. These are actual appeal changes as a result of the healthcare reform. Now, Medicare in of itself is a totally different entity, and it operates as such. If you're in original Medicare plan, there's 5 levels for the appeals process that you can use to request coverage for an item service that you think is medically necessary. The first level, you can use the Medicare summary statement, which is comparable to the explanation of benefits in a non-Medicare plan, to request an appeal, which is called a redetermination. You should carefully review the Medicare summary notice and follow the instructions for requesting an appeal. You must circle the item or service that you disagree with, explain why you disagree, sign the Medicare summary notice, and then send it back to the Medicare contractor identified in the appeal information section of the Medicare summary notice. You can also write a letter. Your request must include the following information: your Medicare health insurance claim number on your red, white, and blue card, the specific service and or items for which a redetermination is being requested, the date of service, your signature or the signature of your authorized or appointed representative. You should then attach to your redetermination request any supporting documentation you believe may help your case. For example, you should include copies of the medical bills and copies of the Medicare summary notice. Second level is if you disagree with the redetermination decision, you have the right to ask for a second-level appeal called a reconsideration. You should read the redetermination decision carefully because it will explain how to ask for a reconsideration. A qualified independent contractor that didn't take part in the first appeal makes the reconsideration decision. And you can also attach a letter as well. And then you go on down the line. If they uphold that denial, then you can appeal to what's called an administrative law judge. And then, if that is still upheld, that denial is upheld, you can appeal to the Medicare Appeals Council. And then finally, the fifth and binding level appeal is to the U.S. District Court. Next. Appeal resources. We have written a very informative guide that's called the Guide to the Appeals Process that is also housed on our website at patientadvocate.org. And under the Resources tab, you can click on the major guides and directories that we have available here at the Foundation. That also has sample appeal letters in it and basically some step-by-step instructions on how to navigate through the appeals process. Also, if you happen to be working on an appeal for a Medicare claim, all of the appeals forms are available on their website at medicare.gov. They are online in the left menu bar, and they are also printable. There are no special rules for filing an appeal to Medicare other than time limitations. We also encourage you to use the Medicare Coverage Database for accessing coverage determination material to aid in your appeal. I use that frequently here at the Foundation, even if it's not a Medicare claim that's been denied. I can use that for the non-Medicare insurance companies that offer policies as well, because if Medicare covers it, that is a big arguing point, if you will, that we would want to include in our appeal, because Medicare is widely known, widely respected as the Mac Daddy, if you will, of insurance benefits. Now the fun part, writing the actual appeal. It's important before you get to this point that you gather important pieces of information. First and foremost, you're going to need a copy of the insurance denial. You're going to need to know exactly what the insurance company is denying and why they are denying it. Then you're going to need to see a copy of the policy or the plan language. The policy and the plan language basically is the contract between you as the beneficiary that has been set up either by an employer-based plan or an independent or an individual plan. It says everything that they're going to cover for you as their beneficiary and everything that they are not going to cover. They're also going to tell you what type of insurance policy that they are, whether they're self-funded, self-insured. They're also going to tell you about what your appeal rights are. So here at the Foundation, I have tried to make it as first and foremost, when we're gathering information to do an appeal process, that plain language in its entirety is beneficial, because while we may not need to go to 1 or 2 pages, we may need access to like 5 or 6. Then we're going to need to have supporting medical documentation. If this is a pre-cert for a particular life-saving surgery, and the doctor wants to go in and the doctor wants to take out one of your kidneys, you're not going to want the doctor to have free rein and say, yep, because the doctor said so, we need to go in and take out my kidney. There needs to be some checks and balances, and provided that doctor can back up the medical reason, the medical necessity why he thinks he needs to remove your kidney, because there are abnormal, let's say, blood results, there's abnormal scans, whatever the case may be. You've got an infection in your blood because you know this kidney is not functioning properly. All of that information needs to be included in the supporting medical documentation. Finally, and last but not least, you need to have adequate peer-to-peer journal documentation that supports the prescribed treatment modality. If this is a standard of care practice, that provided we can prove that it's medically necessary to take out your kidney, then the only thing that should have to be proven in that instance is medical necessity. Now, if they want to go in, and they want to go in, let's say, through your mouth and shoot a tube down and then cut through an organ or two to get to the kidney to take it out, my guess is, as I'm sure it is yours, that's not the standard of care looked upon method of removing a kidney. So, as long as it's not something, and I totally just came up with that off the top of my mind. I don't mean if that sounded curt, that was not the intent. I just want you to know that it seems crazy, because that is, and for that, I wanted to make sure that you were clear and that we weren't oversimplifying it for you, so that you could get a good handle on what I meant when I said peer-to-peer journal documentation. I should be able to pick up a peer-to-peer journal article in, let's say, a urology magazine that says this is how we go in and do certain urological procedures. Next slide, please. What you're going to want to include in the appeal letter is your full name, your health insurance claim number, your address, the reason why you're appealing, any evidence such as medical records that you wish to include. You can also ask your prescribing doctor for information that may help your case. That's pretty important when it comes to moving forward with a particular thing. So the evidence has to be in the medical records that you want to include with that particular appeal. It's instrumental that you do look at going back to the prescribing doctor to make sure that you get him to write you a well-rounded letter. Also, supportive articles, journals, or documents as well that may be beneficial to aid in getting a particular denial overturned may also be considered when submitting information. After all of the facts are gathered, now you're ready to compose the appeal letter. The burden of proof lies with the treating physician and the letter of medical necessity. The letter should clearly state the clinical documentation of the patient and the need for, let's say, genetic testing or treatment, lab, surgery, what have you. It is highly recommended to include excerpts from the physician's letter and incorporating the clinical literature surrounding a particular disease process. Finally, you want to make sure that the direct plain language interpretation is tied in with the clinical standing of the patient. And this is the fun part, because this is where you make your argument. And unfortunately, your argument doesn't lie in just one particular burden of proof that the doctor says, I have to have my kidney removed with this tube that he sends down my throat to pass through a couple of organs just to get to my kidney to take it out. It needs to be clinically pertinent in the clinical community, and it needs to be standard of care. Hindrances to appealing successfully, they can be things such as benefit exclusions, limited contracts covering prescribed services, decreased levels of benefits, high out-of-pocket dollars, whether it be deductible or coinsurance, a knowledge deficit for patients who have treatment and assume that it's going to be covered by their plan, medical costs that are not covered by insurance policies sometimes can be deducted from the annual income before taxes. The amount of cost that you utilized and that you spent in medical expenses for the previous tax year has to exceed 7.5% of your adjusted gross income. Medical costs can include doctor's bills, drugs, prescription costs, medical supplies, and anything that's related, including transportation and lodging. We highly recommend that if you are someone with a chronic or debilitating condition, that you can actually refer to the IRS's website and download publication number 502 that has to do with medical and dental expenses. If your income is $30,000, then you could deduct out-of-pocket medical costs that exceed $2,250. Utilization of hospital support staff. If you need help, a good place to start is with the social worker, financial counselor, or nurse at the hospital where you are being treated. These people are the most knowledgeable about community resources who help offer help as well as internal programs that the hospital funds that they may have for cancer patients. Remember, don't ignore your bill. If you receive a hospital bill, even if you say, I'll never ever be able to pay it back, I'm just going to throw it on a stack on the paper until my newspapers pile up, don't ignore it. It's no different than if you're going to pay your light bill, or you're going to pay your house payment, or you're going to pay your water bill, or you're going to pay for your car payment or your car insurance. You have to make sure that those payments are made on a regular basis. Now, when we talk about debt relief crisis here at the foundation, we tell you where to start and what needs to be paid first. Obviously, you need a place to live. Obviously, you need food on the table, and obviously, you need medications. We can sometimes help you prioritize. We can do some budget lifestyle changes. If you have a hospital bill and you know that you're not ever going to be able to pay it, even if you were to make payments for the rest of your life, we can help you navigate those hardship programs that are available at the hospital. The underinsured and patient assistance. Copayment assistance can be found at nonprofits, and pharmaceutical funding exist, both privately and governmentally insured, Medicare, disease-specific funds which are ever-changing. There are two organizations that we know of that's pretty consistent across the board with premium assistance. That's through the Healthwell Foundation, which it is disease-specific, and also the Leukemia Lymphoma Society Copay Assistance Program as well, that's also disease-based. The disease-specific charity, diagnosis-specific and usually need-based, patients typically must be in active care or limited post-treatment window, funding for medical expense assistance and household stabilization, national charities for families with children or pediatric cancer patients, monies for special populations, musicians, artists, flight attendants, registered nurses, truck drivers, federal employees, and the list can go on. There are some national copayment programs. One actually, believe it or not, and I've been here almost 8 years at the foundation, that I just learned about when I was putting this presentation together, and that is the assistance fund, that fund there at the top. And I had the opportunity earlier today to go in and look, and it's a copay program that provides eligible underinsured individuals with financial assistance to cover all or part of the individual's out-of-pocket cost for the supported medications. These programs give individuals the ability to afford their medications. And when I went to click on the Assist Fund and E-Enroll button, they have different disease categories. We do a lot with cancer here at the foundation. So I'll just give you a few. They have breast cancer copays. They have colorectal. They have multiple myeloma. They have multiple sclerosis, which is not a cancer. They have MDS. They have some non-small cell lung cancer. They have some psoriasis. They have a rheumatoid arthritis. And they also have a wet eye, age-related macular degeneration, along with some C. diff-associated loose stools and colorectal cancer and Crohn's disease. I started going through and clicking on the Apply button, and some of them have already run out of their funds, which you frequently will find. And I tell patients that we talk to on a daily basis that due to the state of so many Americans that have been out of work for so long, when folks aren't working, folks aren't donating. They're not given to their charity of choice. That way, and that just means, unfortunately, that there are fewer dollars to actually help folks out there that are in need for those particular copays because they are underinsured. There's also cancer care, which has disease-specific funding for pharmaceuticals as well. Some of them also have the medication-specific drug. In other words, it may not just be lung cancer. It may be lung cancer, let's say, in Tarceva. So that you have to look, when you look into each of these copays, you have to be clear and make sure that you understand that what the criteria is for each particular copay organization. They all operate a little bit differently. Some of them have a look-back period. Some of them will look back 3 months. Some of them will look back 12. Some of them will look at, we'll go from this point forward. In other words, we don't care that you've already spent X amount of dollars or you have a bill for your Tarceva because it's a specialty pharmacy drug. It'll go from there forward. Chronic Disease Fund as well, that's disease-specific, as is HealthWell, Leukemia Lymphoma Society. Remember, Leukemia Lymphoma Society is also the one that has the premium assistance as well. And their NORD is another good one, the National Organization for Rare Disorders. Patient Access Network, and of course our copay relief program here at the Foundation. Patient Services Incorporated as well.
Tanya, I just want to mention we only have a few more minutes, so just so we have time for questions, if you want to try to get through your last few slides.
Okay, thanks. The National Underinsured Resource Directory is an online interactive tool that is found under, there is not, the website's not on here. If you go under patientadvocate.org/resources, you can find that there. This is a great directory that it's interactive. You can point and click and answer some questions that pertain to your situation. Healthcare reform is set to expire in 2014 with the implementation of exchanges. Now, right now we have the federal pre-existing condition insurance plan, which if you have a qualifying health condition, you're uninsured at least 6 months prior to enrollment, they provide its major medical, comprehensive benefits, capped out-of-pocket costs, plan options, etc. And then there are some state-issued high-risk insurance pools. This is a viable option when COBRA expires. There are comprehensive benefits as well, and they are for the insured with high deductible and catastrophic coverage. There are only like 35 states in the union that actually have these state high-risk pools, and as this year progresses and we learn more than we ever need to know about these exchanges, we will benefit from that knowledge, and I fully anticipate these pools to go by the wayside. Health insurance exchanges. The Healthcare Reform Act requires the health insurance exchanges be established in each state. Individuals and small employers are able to enroll. Small employers are defined as those with no more than 100. Large employers will be able to enroll into the exchanges in 2017. There's also going to be a premium subsidy between 133 to 200% federal poverty. They can purchase plans through the exchanges. Insure Us Today is an informative, collaborative effort of stakeholders to add clarity, to take the confusion out of healthcare reform. Our goal is to help you improve your understanding of the benefits that you will experience as a result of the Patient Protection and Affordable Care Act. And if you notice on the timeline, on the blue rectangular bar above, just to the left of that sweet little boy's eyes, if you click on the timeline, it gives you the year. And you can click on the year, and it tells you everything that is due to roll out that year. They also have a dedicated case manager at the toll-free number on your screen. And finally, we have included a list of the publications that we have actually written here at the Foundation on different things to make things a little bit easier to understand, whether it's the disability process, the appeals process, first my illness, now job discrimination. We also have about 19 series, and it's a Greater Understanding pamphlet series, lighting the way to clinical trials. And we also did a major guide for the pediatric publication about 5 years ago called Too Young to Be Ill. And finally, these are our contact phone numbers for both the foundation and our copay program. And we certainly do thank you for taking the time to learn about our mission so that we can partner with you to navigate through some issues that you guys are going through. Thanks, Elizabeth.
Thank you so much,
Thanks
Tanya
so much.
and Brendan. We'll just do a couple questions, and then folks can email me questions, and I can pass them along to Brendan and Tanya, the ones we don't get to. So we'll just do a couple quick ones right now. There was a question about back on this, I think it was on a slide about types of appeals, about what EOB stands for.
EOB stands for Explanation of Benefits. According to any insurance company that you are insured through as a beneficiary, they have to give you, as you go to the doctor or as you go to have blood work or as you go to a scan, and a bill is made to the insurance company, that insurance company has to not only send back what they paid, what they didn't pay, what went to your deductible, to the provider that submitted the bill, the claim, but it also has to go to the member so that we as members know that we had a $5,000 PET scan. It's only worth about $1,500. $1,000 of it's going to your deductible, and you owe $500 in coinsurance. Now, I just did that off the top of my head, but that's what it is. It's an explanation of how your insurance company paid for your claims.
Okay, great. There was a question about if you have any tips for appeals from denial of disability benefit coverage from a private insurer.
You're talking about the short and long-term disability through the actual employers? Is that what they're talking about?
I can see if they respond to that.
If that's the case, I can tell you this, Elizabeth, it's the same premise that you would do for Social Security disability. If there has to be, you guys will have at some point submitted a request for benefits either from your employer, short or long term. And basically what that means is something has happened. Let's use maternity as that. You're going to be out 6 weeks because you've had a baby. You're going to go out on short-term disability. There has to be a doctor certification why you're going to be out that long. There has to be a paper trail, if you will, between the doctor's office and the employer, not to divulge all of your private health information, but to actually state patient's going to be delivering on this day, induced on this day, baby should be here obviously the same day, and then she's going to be out at least 6 weeks for postpartum care. She won't be allowed to come back until those 6 weeks are up. That type of information has to be clear. In other words, the short-term disability policy, there's a contract involved with everything. There's a contract with Social Security disability. It's not one you print off and go look at, but Social Security disability does have guidelines. The Social Security Administration does have guidelines as well. Now, the private employer policies through your, let's say, your Merrill Lynch or your Mutual of Omaha or Nationwide, whomever, they have whatever the employer has purchased on behalf of the employee that information is housed in the actual contract language. So what that means is it's the same thing with an insurance appeal. It's no different with your homeowner's policy or your auto policy. The policy's clear on what's covered and what's not covered. If you're not deemed disabled through Social Security, or the short or long-term carrier says, I'm sorry, but we'll give you 6 weeks for postpartum, but we're not going to give you any longer. We feel that's sufficient time for you to heal and get back to your normal routine and get your newborn acclimated, to life now. So it's those standards that are kept. It depends on what's in the policy. And remember, if you don't hear anything else than what we've done and talked about in this presentation today, there are no two policies that are created equally. That has to do with medical insurance, that has to do with short-term disability, etc.
Okay, the Patient Advocate Foundation's case management services, are they available for all diseases, or are they disease-specific?
They're not disease specific, but it does have to be a chronic, debilitating, or life-threatening condition.
Okay. You know what, I think we're running over, so we kept track of all of your questions, so we will try to get those answered via email after the presentation. To get a copy of the slides, you can email me. You should all have my contact information. I sent everyone an email this morning, but that is just Elizabeth@NeedyMeds.org. So that's ELIZABETH@NeedyMeds.org for a copy of the slides. And again, we'll try to get all those questions you typed in answered throughout the week and next week. And also a copy of the video will be up on our YouTube page if you want to check back onto that. I also just wanted to briefly mention when Tanya was talking about the disease-specific assistance, there is also a section on the NeedyMeds website you could check out that lists all of those foundations. If you go to our diagnosis-based assistance section, you can look up your disease and find out all of the programs and foundations that help people based on that diagnosis. So I just wanted to mention that. And since we are out of time, I think we're going to finish up. Thank you very much, Tanya and Brendan, for doing this presentation for us. It's important for us here at NeedyMeds to be able to educate people about not just all of the resources that we list on our website, but all those other resources and ways to afford costs of healthcare and medications, because we know, and I think you know, that everyone's kind of struggling with that right now. So we're always looking to educate people, and hopefully this was a helpful presentation for everyone.
Thanks
and
so much,
if you're in the Northeast,
oh,
go ahead.
I was just thanking everyone in attendance. Thanks everyone.
And if you're in the Northeast like we are, good luck with the snowstorm tomorrow. And I hope everyone has a great rest of their afternoon. Okay.
Thanks, Elizabeth. Take care.